Prostanoids are lipid mediators synthesized from arachidonic acid within cell membranes. The cyclooxygenase, or COX, enzymes catalyze this conversion to regulate local tissue homeostasis, pain, and fever. Non-steroidal anti-inflammatory drugs, or NSAIDs, are designed to suppress this systemic pathway to dampen these inflammatory responses. But blocking this pathway exposes specific vulnerabilities across the body: the gastric mucosa, the renal filtration system, and cardiovascular hemodynamics. The exact toxicity profile of any given NSAID is determined by how it splits its inhibitory power between two distinct enzyme isoforms, COX-1 and COX-2. Preventing drug-induced organ failure requires mapping the differential expression of these two specific enzymes. The arachidonic acid cascade diverges into two pathways. The COX-1 branch is constitutively expressed, generating a steady baseline of prostanoids for continuous housekeeping functions. COX-2, however, remains dormant until violently upregulated by inflammatory cytokines like interleukin-1 beta. Once triggered by injury or infection, COX-2 drives the massive prostaglandin surge responsible for chronic inflammation and pain. The pharmacological objective is to selectively target the inducible COX-2 enzyme driving the inflammation, while sparing the constitutive COX-1 enzyme maintaining baseline physiology. Traditional NSAIDs, like ibuprofen and naproxen, lack this precision. They are non-selective, inhibiting both COX isoforms with similar affinity. In the stomach, this lack of selectivity removes a vital defense. A thick mucosal barrier relies on baseline COX-1 activity. When blocked, mucosal production stops. The barrier dissolves, exposing epithelial cells to corrosive gastric acid. The resulting tissue degradation frequently progresses to superficial damage, peptic ulcers, and acute gastrointestinal bleeding. This specific gastrointestinal toxicity is the direct mechanical consequence of shutting down a baseline housekeeping enzyme. The kidneys operate under slightly different dynamics. Under normal conditions, renal blood flow does not depend heavily on prostaglandin synthesis. However, when a patient experiences a compromised state, such as hypotension, volume loss, or dehydration, the initial blood pressure driving into the kidney drops. To compensate, the kidney synthesizes autoregulatory prostaglandins. These force the preglomerular afferent arteriole to dilate, preserving pressure. But an NSAID blocks this precise defense. The arteriole clamps shut, internal pressure plummets, and filtration fails. Removing this compensatory vasodilation is exactly how NSAIDs precipitate acute kidney injury in compromised patients. To solve the severe gastrointestinal toxicity caused by non-selective blockade, highly selective COX-2 inhibitors, known as COXIBs, were developed. The strategy relied entirely on the assumption that COX-2 had minimal expression under normal physiological conditions, but the vascular system breaks this rule. This cross-section highlights a major exception. COX-2 is constitutively expressed in the endothelial layer. These enzymes constantly synthesize prostacyclin, or PGI2. This localized vasodilator keeps the vessel relaxed and ensures passing platelets remain dormant. Endothelial COX-2 provides the body with its primary antithrombotic shield. This shield is counterbalanced by a second mechanism. Platelets rely exclusively on the COX-1 isoform to synthesize thromboxane A2, or TXA2. Thromboxane is the exact functional opposite of prostacyclin. It triggers vasoconstriction and aggressively drives platelets to clump together. Normal cardiovascular homeostasis is maintained by a precise balance: endothelial COX-2 generating relaxing prostacyclin against platelet COX-1 generating aggregating thromboxane. A selective COX-2 inhibitor, like Vioxx, destroys this equilibrium. The prostacyclin side shatters, leaving thromboxane completely unopposed, tipping the scale entirely. The resulting hypercoagulant state dramatically increased the risk of myocardial infarction and stroke, leading to the clinical failure and subsequent market withdrawal of Vioxx. The biochemical imbalance between PGI2 and TXA2 acts as the mechanical driver for drug-induced stroke and heart attack. Categorizing NSAIDs by their isoform selectivity defines their distinct clinical risk profiles. Non-selective NSAIDs carry high gastrointestinal risk by blocking COX-1, but present a lower cardiovascular risk because they suppress both pro-clotting and anti-clotting pathways simultaneously. Conversely, this matrix shows that selective COX-2 inhibitors successfully lower gastrointestinal bleeding, but at the cost of significantly higher cardiovascular risk due to unopposed thromboxane. Celecoxib is the only selective COX-2 inhibitor remaining on the U.S. market, carefully weighed against these strict cardiovascular limitations. Modulating the eicosanoid pathway forces a systemic compromise. Safe prescribing requires matching the specific isoform affinity of the drug to the exact physiological vulnerabilities of the patient.